everyone, and welcome to the April 2026 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Mike Rickles from the University of Pennsylvania.
And I'm Alice Cheng from the University of Toronto, and we are your co-hosts for this podcast series.
Welcome to April, everyone. Spring is definitely in the air for those of us in the Northern Hemisphere.
And I am personally very much looking forward to warmer weather and not having to shovel snow for at least another 6 months. How about you, Mike? I know you love to ski, so not sure if you're more of a winter or a summer guy.
Well, I really like to have them both, Alice. And now that it's warming up, I'm ready for the fish to start biting. And, that snowpack is so critical for the health of our rivers and streams. So you really need to have a good winter to enjoy a good summer. Is that going to be our question this month to know us better?
Oh, no way. No way you get off that easy, Mike. Good try, though. All right, so here's the question for this month. So just to give it context, a number of years ago at the Diabetes Canada conference, we asked all of our plenary speakers to select a song that we would play as they walked onto the stage. So a walk-up song. And to be honest, I got to say, every single one of our plenary speakers, I think, spent more time worrying and choosing their walk-up song than their lecture per se. And we had some really great ones over the years, some including mini performances, either dancing or playing the guitar and singing. Like it was really quite cool for me and the rest of the audience to get a glimpse into the human side of, these famous lecturers who are coming to give the plenary speech. So it was a very fun experience. So therefore, Mike, I've bought you some time with that preamble. What would be your walk-up song? And very importantly, can you sing some of it for us?
Well, I definitely can't sing anything, Alice. And you should know that after listening to me previously attempt to talk like a pirate for you.
That's right.
There is no way my tone deafness will allow for this audience to suffer through any of my singing. But you do have me thinking about summer and fishing. And so a song that comes to mind for me is The Music Never Stopped, written by Bob Weir and John Barlow.
Oh.
What about your stage song, Alice?
Well, before I get to that, I don't think I've ever heard of that song, Mike. So I am going to search it when we are done this. And I look forward to hearing it. So for me, as I mentioned, it was for the Diabetes Canada conference. So I had thought about this. I had thought about, okay, so if I am giving the plenary lecture, what would I pick? And I had it all sorted out. So I'm a huge Star Trek fan. So I had it all figured out that I was going to wear a Starfleet uniform. I couldn't decide between a red Captain one or the blue Beverly Crusher one, but I was going to wear a Starfleet uniform. And then the stage would be black. And then we would do the Star Trek theme. And then we would start, instead of space, the final frontier, it would have been diabetes, the final frontier. And then I had a whole thing written out in my head as to how I was going to change all of those lyrics and make it relevant to diabetes. But then, of course, none of it could happen because when I was invited to be the plenary lecturer, it was COVID. So then it was all virtual and I never got my chance to do the walk-up thing. So if anybody listening to this podcast is running a conference where they're going to organize for a walk-up song, I got it all planned. So hopefully I'm just putting it out there in the universe.
Well, clearly way more thought has gone into your walk up than mine, Alice. And I do hope to get to see that one day. Now, on that note, why don't we go ahead and launch into the April 2026 episode of Diabetes Care on Air. Alice and I will each conduct an interview with authors of feature articles as per our usual routine, and that'll be followed by our rapid exchange segment where Alice and I will each pick 3 articles of particular interest to us.
Let the fun begin. One of the feature articles from the April 2026 issue of Diabetes Care is an excellent narrative review entitled Challenges and Opportunities to Improve Care for Type 1 Diabetes in Older Adulthood by Dr. Anna Kahkoska as lead author and Dr. Medha Munshi as senior author and colleagues from across the United States. I'm very happy to be joined by Dr. Anna Kahkoska, who is an MD with a PhD in nutrition an assistant professor in both the departments of nutrition as well as medicine at the University of North Carolina at Chapel Hill. She is also the co-director of the North Carolina Diabetes Research Center Human Studies Consultation Core. She is joined by the senior author, Dr. Medha Munshi, the one and only Dr. Medha Munshi, director of the Joselyn Geriartic Diabetes Program and professor of medicine at Harvard Medical School. Welcome to you both, Anna and Medha, and so great to have you both on the podcast, and a huge congratulations to you and your colleagues.
Thank you so much.
Thank you.
So maybe we can begin by discussing why you chose to undertake this narrative review. I mean, type 1 diabetes in older adults is frankly not something that we may have worried about as little as 20 or 30 years ago. I mean, certainly when I started as an endocrinologist over 20 years ago, we were seeing older adults with type 1, but not like we are now, right? Because I think it's just a matter of accumulation of time. And in some ways, this is a very happy problem to have, and one that certainly needs to be addressed. So tell us more about the epidemiology and the questions that you wanted to answer.
Absolutely. We decided to undertake the narrative review to highlight the unique challenges that people with type 1 diabetes and their care partners and their care providers are facing, especially as more and more people with type 1 are living into their older adulthood years. So we were specifically motivated to focus on the population based on a number of epidemiologic studies that show that type 1 is increasingly common in older adults, and the prevalence in this age group has actually risen dramatically over the past 3 decades. And this is partially attributed to increased life expectancy among people with type 1 diabetes, as well as new onset cases that can occur in middle and late adulthood. So in the US, we think type 1 accounts for between 5 and 10% of Medicare beneficiaries. So although most clinicians are still more frequently managing older adults with type 2, that may be changing, and we wanted to develop a resource that laid out practical considerations for glycemic management, for care transitions, and for the optimized use of diabetes technology in older adults with type 1.
Okay, great. Thank you. So there was one particularly poignant sentence that stood out to me as I was reading this, and you wrote the following: "It is not simply the age of the individual, nor a simple count of the number of complications, comorbidities, or medications they take that dictates the treatment plan and associated goals, but rather how these factors are affecting the person's function, quality of life, and longevity, and that should guide shared decision-making on optimal person-centered T1D management." Now, that sentence was just really well written, and I think, like I said, really poignant and made a lot of sense. So can you just expand a little bit more on that particular topic?
Yes, so that sentence actually is really getting at the patient-centered philosophy of care in this older population rather than the disease or the age-centric care that typically we think about. And it reflects a very deliberate shift away from using this chronological age or the number of diseases or the number of medications as the proxy that drives whether the people should be managed aggressively or conservatively in this population. And when the decisions are made primarily based on this age or numbers, then there is a risk of either over-treatment or under-treatment in this population. The other important aspect of managing diabetes in aging population is what matters to them, right? As an overarching sort of a concept. And that drives that clinical decision making in how this diabetes and its treatment would intersect in patients' outcome of interest. They want to be functional, they want to be independent, they want better quality of life. And then these dimensions are dynamic, right? So they may change with any kind of acute illnesses, any social transitions, loss of care partner, or progression of these diseases. So regular assessment rather than one-time adjustment, taking into account all these factors, focusing towards what matters to the patient at that time is what this sentence is sort of telling us.
Love it. We should, oh my goodness, talk to our patients and listen to them, right? I think that's really what you're saying, but also the whole context of the individual, not just data.
Yeah, and if you look at the 5 principles of geriatric medicine, they call it 5 M's. It is the medications, morbidity, mentation, mobility, and what matters. And that's the idea.
Love it. Beautiful. Thank you. Now, you started the review by describing persistent factors and then age specific factors. So let's maybe start with the persistent factors. So, what did you mean by that? And what are those persistent factors?
So, as Maida just said, we know that type 1 diabetes management is already highly individualized. And so, we wanted to develop a framework to delineate which factors of type 1 diabetes care and self management are relevant over the life course, no matter how old someone is, and then distinguish a few critical factors that may require additional or new attention in older adulthood years. So, those persistent factors refer to the key aspects of type 1 care or self management that we think are relevant over the lifespan. For example, all people with type 1 diabetes need insulin. They or their care partners are always responsible for an intensive self management routine, including glucose monitoring and insulin administration, and making adjustments for changing diet, activity levels, stress, illness. We know advanced diabetes technologies can be helpful tools regardless of age. And we also highlight the importance of individualized glycemic goals, screening for and addressing social determinants of health, and ensuring access to evidence based psychosocial care.
Okay, so those are the persistent factors that someone living with type 1 diabetes, regardless of age, need to bear in mind. So, then what were the age specific factors?
Yeah, these are the aspects of type 1 care and self management that may require additional or new attention in older adulthood years. So, one age specific factor is increased risk of hypoglycemia in this age group, which requires ongoing assessment of risks and benefits and glycemic goals. We also talk about the impact of accruing comorbidities, diabetes related complications, or geriatric syndromes that may impact on someone's capacity to self manage independently. And we talked through different needs for diabetes education, specifically around learning new diabetes technologies, and then special risks that may occur in transitions of care or in circumstances where the availability of care partner support or other social support may be changing.
So there's a lot that we could dive into in this particular review, but I want to leave some things for our listeners to enjoy when they read the full review. I do, however, want to take a deeper dive into technology use. And Anna, you sort of brought up that briefly in what you were just talking about. So, specifically about technology use in the older adults with type 1 diabetes, particularly CGM and AID or automated insulin delivery. There is an ageist attitude out there, without question, and an erroneous assumption that all older adults cannot handle the technology. So let's start with, let's say, CGM. So, what are your thoughts on CGM in older adults? Good idea, bad idea, special considerations? What do we need to think about?
Actually, it's yes, yes, and yes. All three of them. And you are absolutely right that the ageism actually can be reflected in how patients themselves think and how clinician thinks. But it again leads to this concept of patient-centric sort of evidence or patient-centric thinking that needs to be present when you are thinking about starting CGM in these older adults. And if you look at objectively, the benefits of CGM are no different in older adults than in the younger adults. So CGM in older adults have shown to decrease hypoglycemia, improve all the glycemic parameters, improve quality of life, and also decrease diabetes related stress, both in patients themselves as well as in their caregivers. However, to ensure that the patients are receiving benefits and not thinking of technology as a burden, it's important to identify the why of that why are we asking patient to do that, and if that matches, then that is not a burden, it becomes a benefit. So for example, in a healthy individuals, older adults, getting the time in range, maximizing time in range or better glycemic control that leads to less complication is a very reasonable why, versus sometimes even in people at end of life or in very poor health, decreasing risk of hypoglycemia or decreasing monitoring burden can be an excellent why, an excellent indication. So I think if we match that, then that becomes the important part of diabetes management. without being the burden.
Good. I love the idea of turning burden into benefit. And I mean, that concept applies to life in many ways, right? So I really like that. And then along those lines, you propose different CGM metric targets in older adults with a specific hypoglycemia buffer, I believe is what it was referred to. So can you talk more about that?
Yeah, I think I'm really excited about this whole concept of hypoglycemia buffer. The hypoglycemia buffer is a very deliberate safety margin above 70 milligram per deciliter built into the CGM interpretation and clinical decision making. So instead of thinking about and focusing on hypoglycemia as less than 70 milligram per deciliter and then treating the hypoglycemia once it occurs, the buffer sort of emphasizing prevention of glucose from ever getting close enough to hypoglycemia that a delay in response could actually make it get worse and cause harm. So conceptually, this buffer zone sits between the euglycemia and hypoglycemia, and that provides a lead time to intervene. So one could think that hypoglycemia less than 70, the goal in some of this population should be zero. We don't want to go there. However, hypoglycemia buffer zone, which would be somewhere between 7 to 90, can be individualized. So people who still can have a tighter control, we have a shorter buffer or lower buffer zone, or you can have a higher buffer zone. And that is a much better way of avoiding hypoglycemia in this population, where certainly the risk of hypoglycemia far outweighs any benefits when we can have in tighter control.
And I look forward to see as this hypoglycemia buffer zone concept becomes more and more widely adopted. But conceptually, it makes a lot of sense, makes a whole lot of sense. So I started by saying that I wanted to talk about technology in the older adults, and we're talking CGM and AID. I don't think we're going to have time to necessarily dive into the AID aspects of it on this particular podcast interview, but within the review, you do dive into that. So I would encourage people to look at that as well, because to me, that is a really current, right now in my clinic, probably today came up issue of either someone already on AID who's now become older and is perhaps developing some cognitive issues, or someone who has not yet gone on AID, but we know should go on AID, but is in that older adult bracket. And, what are the things that we need to cover? So that is discussed within the review, and I encourage everyone to take a look at that. So for the next part that I do want to cover as we start to wrap up is the concept of novel models of care delivery to address the changing needs of the older adults with type 1 diabetes, because we have now and we will have even more older adults living with type 1 diabetes moving forward. So what are some sort of novel models of care delivery that may really help?
We discuss a few in the review, and I think it's worth mentioning that not all of the care models are novel themselves, but rather could be applied in a sort of novel way to address the needs of this growing population. So this includes telehealth and expanded home health, specifically to maintain continuity of care and to address barriers like high burden of clinic visits, transportation barriers, or driving and mobility issues. We also discussed the role for interdisciplinary care teams, like the ones that we see in pediatric endocrinology, to address complex needs and develop plans to promote independent living. And then lastly, we touch on the potential for remote data monitoring to support continuity of diabetes technology use in long-term care settings, and especially for older adults who have type 1, and that may not be the norm there.
Okay. So lots of things to think about, because there's a lot of players within the healthcare system that need to be engaged. And whether we're talking also acute care or chronic care, long-term care and home, I mean, there's all these different moving parts. And I'm very happy to see the review exist though, right? Because we need to talk about this. So what's the big take home that you want our listeners to walk away with?
Well, I think one important thing is that when you thinking about optimizing care for older adults with type 1 diabetes, it's not about doing less. It's about doing what matters the most and doing it in the safest way possible. And the second part of the flip side of that is that when you are thinking about technology use, whether it's CGM or AID, they are both very powerful enablers of the goal, but only if we abandon any kind of thinking about age in numbers, or as we talked about, the comorbidities in number, and rethink the traditional targets and anchor every decision in the person's function, priorities, and what matters to them concept.
And I love that idea. It's not about less, because I think that's the automatic reflex that people have. And I mean, in my own experience with my parents getting older and having witnessed it once when a practitioner suggested, based on age, we're going to do something less. And my father's reaction to that, then I suddenly realized, oh my goodness, like we need to rethink what we're saying, because what he heard was not what the practitioner meant, but was what he heard, right? So I think we need to be very careful about how we maneuver that. Thank you. Thank you for the reminder to do that. And thank you to both of you, Doctors Anna Kahkoska and Medha Munshi. As I mentioned, we did not have time in this interview to cover all the excellent topics that are in the narrative review. I strongly encourage our listeners to read the full paper in the April 2026 issue of Diabetes Care. Big things that I've taken away from it is that we need to individualize and adapt to the changing needs of people living with type 1 diabetes over their entire lifespan. And that will require all members of the care spectrum: primary care, specialty care, acute care, long-term care, and we all got to be on the same page. So narrative reviews like this help put us all on the same page. So thank you to both of you for sharing your expertise with us, and to you and your colleagues for doing this extremely important work. And once again, I encourage our listeners to read the full article in the April 2026 issue of Diabetes Care.
In the April 2026 issue of Diabetes Care is a feature article entitled Persistent Burden of Severe Hypoglycemia and Impaired Awareness of Hypoglycemia Among People with Type 1 Diabetes Despite Technology Use, a follow-up survey. I'm delighted we have joining us the article's first author, Dr. Jennifer Sherr. Dr. Sherr is professor of pediatrics in the Division of Endocrinology and Diabetes at Yale University in New Haven, Connecticut. Welcome back, Jen. It is great you could join us to discuss this follow-up study.
Thanks so much, Mike. I'm really excited to be here today.
And Jen, you joined us 2 years ago almost in June of 2024, together with Dr. Jeremy Pettis, one of your co-authors, to discuss the original survey study that you performed on this topic. And can you start by reminding us of the high-level design and findings of that initial survey?
Yeah, absolutely. So our goal in this study was really to understand, what do real world trends look like for the care of individuals living with diabetes? We know that there's been a lot of changes in terms of technology adoption, and how does that relate to glycemia with real world use, and also with, important outcomes in terms of severe hypoglycemic episodes and impaired awareness of hypoglycemia. And so we were very lucky. We got 2,044 people to respond to our survey. And we found that, there was pretty high adoption of CGM. A good cohort of individuals was using automated insulin delivery. And despite that, there was about 40% of the cohort who wasn't reaching their A1C target of less than 7%. Even more striking was the fact that 20% of the individuals had at least one episode of severe hypoglycemia in the past year. And then really surprising to us was that 30% of people, regardless of the technology they were using, were experiencing impaired awareness of hypoglycemia. So, technology was definitely being integrated by this group, but some issues were persisting in overall care.
Okay. And so now here we are 2 years later, and what questions were you seeking to answer in the follow-up study?
Yeah, so I think there was a few questions that we really wanted to answer. We know technology is rapidly evolving. So, I mean, just looking at the field of automated insulin delivery, it's moving so fast. We're seeing next generation systems coming to market. But more importantly than that, I also think When you think back to continuous glucose monitoring, there was a long lag time from that JDRF CGM trial and then integration into clinical practice. And I don't think we're seeing that with AID. Like, it's really great. People are following the ADA standards of care and getting folks with diabetes onto these more advanced insulin delivery technologies. And so the question becomes like, yes, we just answered it, but like, what are happening in terms of longitudinal trends? Do we see differences? Because there really is reports of growth in regards to adoption, even in this short period of time.
And so, of the more than 2,000 original survey respondents, in this follow-up survey, 1,056 responded and completed the study. And so, of those responses, what did you see changed and what stayed the same in this cohort of individuals?
Yeah, so I think the most important thing to look at first is that the people who responded, to the repeat survey were representative of the entire cohort. They were basically me, female, white, private insurance. And then, obviously their age, duration of diabetes had gone up. What happens in terms of technology use? We saw that in our initial survey, about 91% of individuals were using sensor therapy. On the repeat survey, it was up slightly, 94%. But just as we anticipated, about 18% of the cohort had adopted AID therapy. So we went from a baseline of 50% to almost 2/3 of the cohort now using AID. So that's a lot of AID introduction in a short period of time.
And so the use of automated insulin delivery increased. And also in your paper, you note that there was a modest decrease in hemoglobin A1C seen. Do we know whether the improvement in average glycemic control may have been driven by those individuals taking up use of AID in the interval period?
Yeah, I think that's a great question. Looking at everything with the greater adoption of AID, we saw that our secondary cohort still had 30% of individuals who were not achieving glycemic target of A1C less than 7%. We also found that in terms of impaired awareness of hypoglycemia, that stayed rock steady at 30% of the cohort. So no difference there. And then rates of severe hypoglycemia also really didn't change. About 20% had at least one episode in the past year. 10% had two or more episodes in the past year. So was it the AID system that's making the difference? It's hard for us to tell. And the reason is, as I'm sure you're aware, people have interruptions of supplies. My sensor comes out, right? I'm not using it. We didn't get the exact time of when AID was initiated in some of these folks and the timing of that severe hypo event. So it's hard to say that, AID alone drove changes in A1C. I would suspect that's the case, but I just want to be very honest. We don't have that data to, clearly indicate that's what's going on.
And so this persistence of impaired awareness of hypoglycemia, 30% of the respondents, again, in this follow-up survey, and of those experiencing severe hypoglycemia events, again, 20% of the respondents in the follow-up survey. Are there any additional insights provided by the follow-up survey that can help us explain these persistent problems with those experiencing hypoglycemia despite the overall increased use of automated insulin delivery in this study population?
Yeah, I think that was one of the benefits of doing this repeat survey. When we were writing up the initial paper, we're like, well, what do people think caused their event? And, we're all sitting there going, wouldn't it have been interesting to ask? So we had this perfect opportunity. We're going to send out this repeat survey. Let's ask people what they thought happened. And so 201 respondents who had an episode of severe hypoglycemia recorded, what they thought led to their event. And the most commonly endorsed cause was overestimation of insulin dose or inaccurate carb counting. And the second most commonly endorsed thing was physical activity. As we all know, AID systems are incredible. It's really helped with many things. But currently, with present day technology, we know that two pressure points are meals and exercise. And so, this cohort is saying, hey, guess what? Meals and exercise are what are causing my issues. I think it's even more important that we got to ask people, well, what happened? Where did you treat your severe hypo event? And 90% of individuals said, I got treated at home outside of a healthcare setting. And so it really speaks to the fact that if we are not diligent about asking people, have you had a severe hypo? Let me define a severe hypo for you. We may be missing that in clinical practice. And it speaks to how, you know, we just need to be thinking about capturing all the things that we think are very important in terms of clinical care.
Yeah, that's really great, Jen, because you're right. In our standard practice of examining the last 14 days of continuous glucose monitoring and insulin delivery data, it's easy to assume in a short 15 or 20-minute office visit, hey, everything looks great. And unless we really do ask about all the time spent since their last visit with us, have you had any problems with severe hypoglycemic events? Have you needed assistance with any problematic low blood sugars? We're likely to not get that. It may have been top of mind at the time it occurred, but if that had been several weeks to a few months ago, it may not come up in our office visit. And that becomes important in realizing that there could be additional opportunities for education and reinforcement surrounding meal bolus practices and strategies to reduce the risk for exercise-associated hypoglycemia that may be particularly important for those individuals. Jen, do you have any final takeaway messages for our listeners?
I think I'm a fierce advocate of technology. Like, I love it. It's the standard of care. I'm grateful we're seeing rapid adoption of the next generation systems and just increased adoption of technology overall. But I think really what this paper highlights is that, you know, technology has led to a lot of progress, but it's not a cure. And so there's still things that we need to be working on. And just as we said, asking about severe hypoglycemia, understanding if somebody can feel low, it's really important. And in some ways, even as a person with diabetes, I feel embarrassed that I had, a severe hypo event. I don't want to acknowledge something like this happened to me. But if you give me that permission to share with you something that's going on, it's going to open the door. And I think you have a better relationship with those you treat by setting the stage to let them answer the question.
Dr. Jennifer Sherr, thank you so much for sharing your expertise with us. I really appreciate all I've learned about the persistent problems of severe hypoglycemia and impaired awareness of hypoglycemia that continue to affect our patients despite the increasing uptake of automated insulin delivery systems. And these findings, as you point out, really highlight the need for further clinical investigation to improve interventions for this high-risk population. I encourage our listeners to access the full article in the April issue of Diabetes Care. Let's move on now to the Rapid Exchange segment, where Alice and I will discuss articles we found of particular interest this month. Alice, can you please kick us off?
Absolutely. So this month, I tried to find a common theme in my picks for this month, but I wasn't able to. So consider this a potpourri of stuff that I thought was cool. So my first pick is a multi-center longitudinal cohort study of children with metabolic dysfunction-associated steatotic liver disease, or MASLD, by Dr. Nat Quang Tai and colleagues from the University of California, San Diego, and other collaborators across the U.S. They wanted to find out the relationship between longitudinal changes in liver chemistries and incident type 2 diabetes. They followed 1,035 children with biopsy-confirmed MASLD without type 2 diabetes at baseline for a mean of 3.9 years. The mean age was 12.8 years, 73% were male, and 73% were Hispanic. During the follow-up period, 12.3% developed type 2 diabetes. Now, those who went on to develop type 2 diabetes were more likely to be female, non-Hispanic, with higher BMI-Z scores. Now, increases in GGT, AST, and ALT were associated with a higher risk of developing type 2 diabetes in the independent models. But when all three liver chemistries were considered, only GGT and AST remain significant predictors of incident type 2 diabetes. This means that monitoring GGT and AST trajectories among children with MASLD may provide a dynamic biomarker to identify individuals at particularly high risk of developing type 2 diabetes, providing an opportunity to intervene early.
That's so interesting, Alice. And I'm going to come back to this with relates to one of my picks later on. And intervening early, particularly in the pediatric population, is just so critical, as the RISE study and others have shown that progressive loss of basal function occurs much more rapidly when type 2 diabetes develops in youth than in adults. So anything to head that off before decline really starts to set in is certainly very important. And I think my picks this month also are a potpourri of sorts. So maybe our cool stuff can be a theme together. And my first pick examines thyroid, celiac, and other autoimmune diseases with the risk of type 1 diabetes in young adulthood. So Dr. Gilad Twig from Tel Aviv and colleagues throughout Israel studied almost 1.5 million adolescents without a history of dysglycemia who were registered between 1996 and 2016. And almost 3% of this cohort had a history of autoimmunity at study entry, mostly autoimmune thyroid disease and celiac disease. And with follow-up of more than 10 years per individual, while most of the cases of type 1 diabetes occurred in the much larger number of individuals who did not have other autoimmune disorders, the risk for incident type 1 diabetes was over twofold higher for those with when compared to without a previous history of autoimmunity. So these findings may help to inform population screening efforts that are seeking to expand beyond testing just first degree relatives of those with type 1 diabetes for early stage autoimmune diabetes.
And as we've discussed on other episodes, this movement, I'm going to call it a movement, to do more screening and to help identify people at earlier stage of type 1 diabetes has really picked up momentum, I would say, and being able to determine who those higher risk people are is super helpful, because I think we're still a ways away from general population screening. I mean, it depends obviously what country you're listening from, but certainly in Canada, I think we are a ways away from general population screening. So being able to identify these higher risk groups would be very helpful. And for this audience listening to our podcast, I imagine many are also not just diabetologists, but endocrinologists. So we are absolutely seeing these people with autoimmune disorders, be it adrenal or be it thyroid. So useful information for sure. Thank you, Mike. My second pick is a retrospective multi-center cohort study by Dr. Reineke van der Meer from the Netherlands, along with colleagues from Belgium, Ireland, and Kuwait. They sought to determine the effect of metabolic bariatric surgery in people living with type 1 diabetes and obesity. The cohort included 162 individuals, which is the largest to date, with mean baseline BMI of 40.2 kilograms per meter squared. 1 year after surgery, mean total weight loss was 29.7%. Insulin requirements dropped by 58%. A1C, LDL, HDL, total cholesterol, triglycerides, all improved after surgery. The effects were similar regardless of insulin delivery method, whether they were using insulin pump or using multiple daily injections. Now, the steepest decline in insulin requirements occurred in the early post-op periods, underscoring the need for close monitoring and proactive adjustments. Now, in light of the recent phase 2 results of tirzepatide in type 1 diabetes, demonstrating a nearly 9% body weight loss associated with a 35% reduction in insulin dose requirements, this analysis of people living with type 1 diabetes and obesity experiencing success with metabolic bariatric surgery is a good reminder to us that living with type 1 diabetes does not protect anyone from also living with obesity. So we need to be mindful of treatments for both. And also, as an aside, our assumption that people living with obesity must have type 2 diabetes and the expectation that metabolic bariatric surgery will resolve their diabetes is flawed, and we need to be careful of the very real possibility that the person actually has type 1 diabetes, that we have misdiagnosed pre-op, and that we should not be teaching people to just stop their insulin after metabolic bariatric surgery, but instead be mindful of the possibility that they may actually have type 1.
Thank you, Alice. And this study also points out that for individuals with type 1 diabetes, as we know for those having type 2 diabetes, that bariatric surgery may still outperform medical therapy for weight reduction. So, this is still an important intervention that needs to be considered for our patients with more extreme degrees of obesity. My next pick looks at sodium glucose cotransporter 2 or SGLT2 inhibitor use on diabetic foot ulcer healing, amputation, and mortality. Dr. Clotilde Demortier and colleagues in Dijon, France, examined 452 new patients seen for diabetic foot ulcer from 2022 to 2024 with 1 year follow up. 94 of these were treated with an SGLT2 inhibitor and 358 were not. There were no differences seen in 6-month healing or 12-month amputation rates between those treated with or without an SGLT2 inhibitor. But in fact, healing time was faster and mortality lower in those treated with the SGLT2 inhibitor. So these findings provide reassurance regarding the safety and, you know, perhaps even possible benefits of continuing rather than stopping SGLT2 inhibitors in the setting of diabetic foot ulcer.
And this is helpful for sure because it's unfortunately become routine. Right? I see it all the time where people develop a diabetic foot ulcer, their SGLT2 inhibitor gets stopped, maybe appropriate during an acute infection, but then it never gets restarted and it never gets re-examined as to whether this is even the right thing to do. And then that individual loses out on all the cardiorenal benefits we know SGLT2 inhibitors can bring to the table. I guess for this particular study, and admittedly I did not dive into it any deeper, I'd be curious to see if they controlled for all the other factors, because you would wonder, those 94 treated, how are they different than the 358 who were not? But I suspect, and as I admit, I did not read the full paper, that must have been considered. So I think overall, this is very reassuring data for us to be thinking about. Now, my final pick is a study by Dr. Ravi Ratnakaran and colleagues from the University of Toronto, and shout out to Ravi and his team, which to me, I think further supports my belief that pregnancy literally sucks the life out of you. So they hypothesize that pregnancy may impact the long-term natural history of the pathophysiologic determinants of type 2 diabetes, namely insulin sensitivity and beta cell function. To test this hypothesis, they evaluated the 10-year trajectories of insulin sensitivity and beta cell function in 303 women. They underwent metabolic characterization with OGTT at 1 year postpartum and 3 or more times over the course of the subsequent decade. This allowed for serial evaluation of insulin sensitivity/resistance, beta cell function, and glycemia. Now, of these women, 78 had an additional pregnancy and 225 did not. Not surprisingly, the women who had an additional pregnancy were younger at baseline and more likely to be primates. They had higher insulin sensitivity at baseline and at 1.5 years follow-up, but the difference was gone by 3.5 and 5.5 years. The 10-year trajectory of whole body insulin sensitivity declined more with additional pregnancies, but beta cell function and glycemia were not impacted. So the authors conclude that this provides a pathophysiologic basis for how pregnancy may contribute to a woman's future risk of type 2 diabetes, and therefore the potential for targeted interventions to address this.
Wow, Alice, I think we had all just assumed that the insulin resistance associated with pregnancy just went away at the end of gestation with the passing of the placenta. And these data support a longer term shift in a woman's metabolism that's occurring, which I feel women have been trying to tell us about this for some time now. And I think it's really helpful to see this evidence supporting that women's bodies are different postpartum. And certainly that is really helpful information to have and to understand. My last pick, which is going to come full circle now on your first pick, Alice, on looking at early determinants of metabolic dysfunction, is examining the relationship between CGM sensor glucose, time in range, and time in tight range. So time in range has been traditionally considered between a normal glucose of 70 to 180 milligrams per deciliter, or 3.9 to 10 millimoles per liter. And now this time in tight range, or really normal glucose between 70 and 140 milligrams per deciliter, or 3.9 and 7.8 millimoles per liter. And now looking at these metrics and incident metabolic disease in individuals without diabetes. Miss Anastasia Godneva from Rehavat, Israel, and colleagues investigated over 8,000 individuals participating in the Human Phenotype Project, who each contributed about 12 days of CGM data using the Freestyle Libre Pro. Median time in range, 7180, was 95%. Medium time in tight range, the 70 to 140, was 93%. What they found was less time spent below 140, or the 7.8 millimole per liter threshold, was associated with higher metabolic syndrome traits, including blood pressure, waist circumference, visceral fat, serum triglycerides, alanine aminotransferase levels, and other indices of liver fat, and lower serum HDL cholesterol and nocturnal saturation of oxygen. And these associations with time and tight range were stronger than the relationships when they examined the time below 180 milligrams per deciliter, 10 millimoles per liter. So applying this time and tight range, or its reduced upper limit of glycemia, may help in identifying individuals without diabetes who may nonetheless be at increased risk for future metabolic disorders.
So it almost seems to me, Mike, listening to you, that it's that there's almost like a middle zone, which is that time in that just above. So what is that? That would be like the 7.9 to 10 millimoles per liter in my world, which would be what, 140 to 180 in your world, milligrams per deciliter. That almost is an interesting metric to be a predictor of future risk. And again, you know, the people that you want to intervene and step in, et cetera. And then this also makes me think about, and I get this from patients all the time, even those not living with diabetes who are wearing CGM for some reason. And then they'll always ask, you know, is it bad that I get a spike after eating, but it comes right back down? And it certainly comes down within the 1 hour or 2 hour mark. But is it bad to have that spike to begin with? And I never really know how to answer that, because nothing's quote unquote bad, but I always try to make the point that maybe it's just better to be smoother, but I don't know that to be true. And frankly, here, I don't know if that would translate into the same thing, but it's speaking to that 7.9 to 10 mark, right? So I think these are interesting data, and hopefully we'll continue to expand so we can continue to learn more. So other thing I wanted to add, Mike, was that we usually only are allowed 3 picks for the rapid exchange. And I do want to highlight, though, to the audience that there was a 4th pick, but I'm actually going to leave it for the audience to read because I think it's a really beautiful piece. And my 4th pick was actually in this April 2026 issue, a beautiful piece by none other than the Professor Juliana Chan from the Chinese University of Hong Kong, who was the recipient in 2025 of the Kelly West Award at the ADA Scientific Sessions. So this piece actually captures her inspiring Kelly West Award lecture and really shows why Professor Chan is so deserving of this prestigious award. So I encourage everyone to take a look at that.
Wonderful. And that brings us to the end of the April 2026 episode of Diabetes Care on Air.
Thank you to Drs. Anna Kahkoska, Medha Munshi, and Jennifer Sherr for sharing their experience with us.
And a reminder to all that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. So don't be shy. Send in your work.
And don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for listening to another episode of Diabetes Care on Air.